Okay. Okay, we'll do a bit of cardiology part 2. So we'll start with in our heart, we have our pacemaker cells, our conductile cells, and we have our contractile cells. So our muscle cells, our myocytes. And we have 2 action potentials for these. Don't confuse them. So here we've got our pacemaker cell. This is in our SA node, our AV node. This is the cell we'd have there. And these little line ones, these are our myocytes. Okay. And up here we have conductile cell action potential and a contractile cell action potential. So they're different. So we'll go through what happens in each. Okay, so we'll start off. We start on our nodal cell, our pacemaker cell, because that's what initiates our. It triggers our contractile cells to start contracting. So how we understand that in all cells of our body they have a resting potential. When they get excited, that means they do their thing. So if you excite a muscle cell, it will contract. If you excite an endocrine cell, it will release a hormone. If you excite a pacemaker cell, it'll cause calcium to enter and sodium to enter, and this triggers contraction basically. Okay, so how do we get this resting potential? So this is the same in every cell. So we have our ATPase sodium potassium pumps. So what they do is they kick out 3 sodium and they bring in 2 potassium. Okay, so that's what they do. They're pumping out 3 sodiums, bringing in 2 potassiums, and that's how they work. So overall, that's generally going to bring about a positive charge on the outside of the membrane, a more negative charge on the inside of the membrane. Okay, so that's generally what we're going to have. But what we also have is potassium pumps as well. So these are leaky potassium pumps that lets potassium out. Okay, so as well as this sodium potassium pump having more sodium going out of the cell than coming in, we've got leaky potassium pumps that lets the potassium out. Okay, so overall that's going to even more so affect this positive and negative charge that we have on our membrane. So it's going to be more positive on the outside than in the inside. So overall we've got a potential difference there. So that brings us to our graph. So our resting potential should be around -60 in a conductile cell. Okay? But we need to bear in mind here that although our resting potential is -60 millivolts, it doesn't stay at that. And that's because of these things here. We've got funny channels. So this is what makes a pacemaker cell special in a sense. So these funny channels, they're funny because they're sort of always leaky and always let in, so sodium can trickle in to the cell. Okay? So these sodium channels, sodium's starting to trickle into the cell down its gradient. Okay, so let's think about this. What does that mean for our potential difference on our membrane? So we've said that because of our ATPase sodium potassium pump pumping more sodium out than potassium in, and this potassium pump pumping potassium out, we're saying that it's going to be more positive outside. But what we've got here is our funny channel putting in sodium. So now we've got positive charge coming into the cell. So we've got positive charge coming into the cell. What's that going to affect? If we look to our graph, it's going to start peaking. So we see here, we've got -60 millivolts. That's our resting potential, but we don't have that because we've got our funny channels. So it's always not, it's never resting. So as soon as it's repolarized, it starts going back up. It's like a wave, it goes up and down, up and down. It's like a sine wave. Okay, so these funny channels, over time, we're gradually getting more and more sodium into the cell. So it starts trickling up towards the threshold, which is minus 40 millivolts. Okay, so what I imagine is that the rate at which the sodium enters the cell is just a bit faster than the rate at which the sodium leaves the cell. Because that's the only way that can explain why we're going up still. Okay, so we hit the threshold, minus 40 millivolts, along this membrane. Okay, so it's still more negative in the cell than outside, but we've hit the threshold. So at this threshold, something's going to happen. Okay, so we've got here in red, we've got our voltage gated calcium channels. Okay, so at minus 40 millivolts, okay, our calcium channels are going to open. So calcium is going to rush in. Now, calcium has a +2 charge. So, what does that mean for our graph? It means that our graph is now going to spike because lots of positive charge is going to enter the cell. Okay. Also to note, this channel is slow. Okay. Not so important here, but later on it'll be more important and relevant. So, we're going to spike. Lots of positive charge, and at this point, the charge within our cell is now more positive than negative. So in our cell, it's more positive. We're now at plus 10 millivolts, and the outside is more negative. Okay. All the while, these sodium potassium pumps are still working. They're still happening. It's overpowered by this calcium and sodium influx. Okay, so we call this, on the graph, we call this phase 0. Don't ask why, that's just what we call it. So phase 0 is essentially our depolarization event on the graph, okay? So the phases, best way I can describe this is, the phases apply to both myocardium, like muscle cells, and conductile cells. So the phase 0 in both will mean depolarization, and so forth. We'll touch a bit more on the phases in a minute. So our calcium entered. We're now at this peak on our conductile cell graph. Okay. At this point now, our sodium channels are now going to close. So no more sodium entering. Okay, no more sodium entering our cell, but we still got calcium in there. Okay. Our funny channels are still open, they're still trickling in sodium, so that's still happening. But at this point now, so at 10 millivolts, at plus 10 millivolts, we're going to have another channel open. So our potassium channel is now going to open. Okay? And potassium is going to rush out of the cell. Okay? Is that right? Yes. So potassium is now going to rush out of the cell. Okay. Let's think about this now. So, positive charge in the cell is more positive in the cell. Positive charge is now going to leave the cell. And that means our thing by here, our potential along the membrane is now going to change. So it's now going to be more positive outside the cell than inside the cell. Okay? So what does this mean on our graph? It's now going to plummet back down again, and we're going to be in a phase of like hyperpolarization essentially, where it's now gone past the threshold or gone below the threshold, and it's now reached minus 60 millivolts again. Okay. At that point, our potassium channels are going to close again, and we're going to resume our cycle where this happens as funny channels letting in sodium, and it's just going to keep going up and down, up and down. Okay, so this repolarization where potassium rushes out, this is called phase 3. Okay, phase 3. Repolarization by potassium is phase 3. Potassium out, phase 3. Okay. Phase 4 then is that constant, like sort of gradual peaking up towards the threshold. So our potassium's out, so that's when our funny channels are acting, and they're slowly sort of bringing us back up to our threshold. Okay. So that's what's happening there. All right. So we've also got now, we've got our sodium and we've got our calcium in our conductile cell. So the whole point of depolarizing our conductile cell is to get these two molecules. Okay, that's the whole point of this. So what happens is these diffuse into our myocyte cells. Okay, this is important. So they diffuse into our myocyte cells, which at this point, so before they've diffused in, they're at a resting state. So remember how we talked about our resting state? How is that achieved? We've got our sodium, potassium, ATPase pumps, pumping 3 sodium out, 2 sodium in. We've also got our potassium pumps, pumping potassium out. Okay, so that's how we're going to get an overall positive charge on the outside, overall negative charge on the inside. Okay, so at that point we're at our resting potential on the myocyte, and then these two positive molecules suddenly rush in. So suddenly we've got a lot of positive charge in the cell. So what's that going to mean? That's going to mean our negative charge inside the cell now becomes more positive, and this becomes more negative on the outside. So positive charge enters, and we're going to trickle up towards our threshold because our positive charge, so our resting potential of minus 90 millivolts in our myocyte cells is going to trickle up to our threshold of minus 70 millivolts. So at minus 70 millivolts, that's our threshold. That's the key to sort of a chain of events. So once we get to this threshold, the key's unlocked, the padlock's unlocked, and a channel can be opened. So what channel are we going to open, do you think? We're going to open our sodium channels, okay? So these are very fast sodium channels, okay? Fast sodium channels. So lots of sodium rushes into the cell very, very quickly, okay? What's that going to mean on our graph? If we've got, so sodium plus 1 charge, sodium, lots of sodium is going to rush into the cell. So lots of positive charge entering. That's going to mean the inside of our cell is going to be much, much more positive suddenly. So we're going to have a spike up. So again, this is our phase 0. We've got depolarization happening. Okay, so it's going to spike up and sort of at that plateau level, not a plateau, like the peak point. Okay, at plus 20. So at positive 20 millivolts, our sodium channels are going to close. Okay, so that's like the peak. That's when they're inactivated. So sodium's rushed in, we've depolarized the cell, and we've triggered it, we've activated our cell. So now this sodium channel is going to close, okay? But we've still got the sodium. So all the sodium that's entered the cell is still there. Which bear that in mind, that comes in important in there. Okay, so we've got sodium in the cell, lots of positive charge in the cell. What we need to do is we need to get rid of that if we want to repolarize our cell. So repolarization happens now. So at positive 20 millivolts, two things happen. We've got two channels that open. We've got our potassium channels and our slow channels. Okay, now remember I said that our calcium channels are very slow. So that's important here. So our potassium channel, what's that going to try and do? It's going to try and eject all this potassium. So it's going to try and kick out all that potassium that's been building up in the cell from our ATPase sodium potassium pumps. So that potassium is going to get kicked out. Okay? But at the same time, our calcium is trying to enter our cell. So this calcium starts coming into our cell. Okay? So you might think, well, we've got positive charge coming in, plus 2, but we've also got positive charge leaving. So what's that going to mean? Well, remember the fact that this is slow, so it's a slow channel. So initially, we have lots of potassium leaving. So overall, the charge in our cell is going to become more positive outside. So it's going to dip. So we've got this little bit here, phase 1 is what we call it. So you see that little orange dip down? That's going to happen because our potassium is overpoweringly leaving the cell. So net positive charge is leaving the cell. Okay, that's the best way I can describe that. At the same time, positive charge is entering, but just not as quick. So not enough positive charge is coming in to counter the charge going out. Until we get to a point in our graph where it starts to plateau. Now this is called phase 2. So at this point, the positive charge entering our cell is roughly equal to the rate of positive charge that leaves our cell. So, because our calcium is a plus 2 charge, plus 2, our potassium is plus 1 charge, even though calcium is a bit slower, the fact that it's plus 2 counters it. If it's sort of a weird concept to explain, but essentially the net charge is sort of equal. Same rate going in as the same as the rate going out, charge-wise, not molecules-wise. Okay, so that means our calcium is entering the cell. At this point, it sort of plateaus for about 200 milliseconds. So why is this important? This is important because it's not just one cell we want to contract along in our heart. We want, say, if we've got atrial depolarization, we want all the atria muscle cells to contract together. We don't want sort of everyone contracting every now and then. We want them all to sort of succinctly. So in a syncision, that's what they call it. It's where they all contract together, which is important. Okay, so that's why we've got this delay, this absolute refractory period. Okay, is a technical term for it. So during this, calcium is important. So what do we need calcium for? Calcium is for contraction. So we've got our sodium, which is for depolarization. And after depolarization, we know contraction happens. So calcium comes in. But it's not this calcium that enters that causes the contraction. We've got something called our sarcoplasmic reticulum. Okay? So our sarcoplasmic reticulum, as soon as enough calcium's entered, this sort of triggers our sarcoplasmic reticulum to sort of burst. So all the calcium that was contained in there is now free floating. It can now act, it can now bind to myosin to sort of release the tropomyosin and allow for cross bridges to form. Okay, so the question I had was, well, if we've got our calcium in there and it suddenly bursts, why don't we see a spike on this plateau graph? And that's because, well, if you think about it, we've got the positive charge is already in the cell. Even though it's contained in a sac, the sarcoplasmic reticulum is still in there. So the overall charge is accounted for. So I hope that makes sense. In my mind, if it was in a sac, then it was sort of inert and it wasn't affecting the overall charge, but that's wrong. Okay, so our calcium can now escape our sarcoplasmic reticulum. Bob's your uncle, contraction can happen in unison. Okay, so this delay as well allows for depolarization to continue along to other cells. Because if you think about it, depolarization closest to the nodal cell is going to happen faster than further away. So we want to give it some time to sort of happen together. Okay, after 200 milliseconds, our calcium channels are now going to close. Okay, they've stopped. So now we've got the only channels acting at this point now are our resting potential channels. Just associate them with resting potential. They keep our cell sort of normal and resting. So the only other external channel is our potassium one. So our potassium channel is still pumping all our potassium out. It's frantic trying to get all the potassium out, and overall net charge is leaving the cell. Okay, so our net charge is now going to be more positive outside the cell than inside the cell. Okay, so if we look back on this graph, it's going to plummet back to our resting potential of minus 90 millivolts. Once it reaches our resting potential again, this is going to turn off and it's going to now continue with our resting potential pumps, if you know what I mean. Okay, we've now got phase 4 where this cycle sort of repeats again and depolarization, it starts to go towards the threshold. So phase 4, going towards the threshold, okay? Ready for that all or nothing response. Okay, so that's our cardiac conductile and contractile action potentials. So we know that our conductile cells, they're sort of automatic, they do their own thing. They don't need external input to keep going. These are spontaneous, so they keep going. However, they can be affected by our autonomic nervous system. So our parasympathetic and our sympathetic nervous system. Okay, so how does our sympathetic nervous system affect it? Let's talk about the structure and what it does. So our sympathetic nervous system, that's in our thoracolumbar region. Okay, so it comes out, all the neurons come out from our thoracolumbar region. Okay, so our thoracic and our lumbar regions. So, in the case of the heart, we've got our presynaptic ganglion neuron. It comes out of the spinal cord and it synapses quite close to the spine. So here's our spine and it comes out just a little bit, synapses with our postsynaptic neuron, and it sort of sends our signal. Okay, so between this synapse, we've got acetylcholine. Okay, so from our presynaptic to our postsynaptic, we've always got acetylcholine. Okay, that's our neurotransmitter. And that's the same for parasympathetic as well as sympathetic. However, in sympathetic nervous system, we've got that fight or flight. Okay, so for fight or flight, we want adrenaline or noradrenaline. So our noradrenaline is the neurotransmitter that's released at the end of the postsynaptic neuron. So when our postsynaptic neuron, we've got our presynaptic neuron, comes from the spine to our synapse, to our ganglion. From our ganglion to our effector organ, so in this case the heart, we've got noradrenaline. Okay, so noradrenaline is released and it binds to receptors on the SA node or the conductile cells. Okay, so in our SA node or our AV node. Okay. All right, so when it binds to these receptors, I'll go into more detail on the receptors in a minute, but when they bind to these receptors, it's going to cause our SA node and our AV node to stimulate more calcium and sodium to enter the cell. So if we think about it, we want our fight or flight, we want our heart rate to increase. We want to be able to run faster, we want to be able to be at a heightened sort of alertness. So we want our heart rate to increase. We want our blood pressure to increase, heart rate to increase, that sort of thing. That's what our sympathetic nervous system is for. So when it goes to our conductile cells, it's going to stimulate and sort of encourage our action potential to fire. So how does it do that? It's going to stimulate our calcium channels to open. It's going to stimulate our funny channels. So potentially our funny channels might pump in more sodium than normally. That sort of thing. So anything to sort of get our action potential firing more often. So this might be chronotropic, increasing the speed of our heart. Okay. We've also got inotropic effects, so positive inotropic effects with our sympathetic nervous system. Because if you see here, our postganglionic neurons, they don't just go to our conductile cells, they go to our contractile cells as well. So they go into the walls of like the Purkinje fibers, that sort of area, in the walls of our ventricles, walls of our atrium, and they stimulate our contractile cells to contract with more power, so increased contractility. Okay, how does it do that? So what do we need for contraction? We need calcium. So in our contractile cell, our sympathetic nervous system is going to increase the amount of calcium that enters. Okay, so that's important. So we've got the same neurotransmitter, so noradrenaline is still acting on these two parts. However, in our conductile cell, it's going to stimulate sodium and calcium to enter the cell. But in our contractile cell, it's just going to stimulate our calcium to enter. Okay? Okay, so that's how the sympathetic nervous system helps with our contraction and heart rate. So how does it do that? Our receptors. So we've got four main types of receptors. We've got alpha 1, alpha 2, beta 1, beta 2. We've also got beta 3, but that's not as relevant as that's on adipose tissue and that sort of thing, and we don't have many drugs that target beta 3. Okay. So our alpha 1 and beta 1, if we group them together, these are our stimulated receptors. So in our sympathetic nervous system, if noradrenaline or adrenaline binds to our beta 1 or alpha 1, it's going to stimulate them to do something. Okay? So quickly, what's the difference between adrenaline and noradrenaline? Noradrenaline is our neurotransmitter. Adrenaline is our hormone. So what happens is, most sympathetic nerve fibers have two neurons. We have a pre and a postsynaptic. Okay, so our pre goes to our ganglion, and that links to our post, which goes to our effector organ. However, there is one case where we don't have a postsynaptic neuron. Okay, and that's when our presynaptic neuron goes straight to the adrenal gland. Okay, so our adrenal gland is where adrenaline is secreted. So when our presynaptic neuron synapses with our adrenal gland, it tells our adrenal gland sort of let out some adrenaline into the blood. So adrenaline goes into the blood and it can have a whole body effect. Okay, so instead of our nervous system having to target individual organs and telling them, you know, turn on, turn off, turn on, turn off, adrenaline goes into the blood and it sort of does a coverall, it does everything. And it triggers all receptors it can find. Okay? Sympathetic wise. So, our beta 1 receptors. They're found in our heart and in the juxtaglomerulus sort of cells. Okay, so that's the juxtaglomerular sort of bit. That's associated with the kidney and the renin angiotensin mechanism, which I'm not going to cover now. Okay, but it's also going to be stimulated in our heart. So when I say stimulated, I mean sort of if noradrenaline binds to beta 1, it's going to stimulate it to do something. Okay, so that might be to contract. Okay. So these are the receptors. Beta 1 are going to be on the heart. These are going to be in our SA nodes, in our contractile cells. Okay. So those are the receptors we're talking about here when we're talking about the cardiac cycle. So our beta 1 receptors might be on here. They might be waiting, and when when neurotransmitter binds to it, they might trigger our sodium to enter and our calcium to enter in our conductile cell, that sort of thing. Okay. Our alpha 1 then, when they're stimulated by noradrenaline or adrenaline, they're going to cause our smooth muscle, organs and glands to contract, or they're going to be stimulated. Okay, depending on if they're part of the sympathetic nervous system. So for example, our peripheral blood supply, our vessels are going to contract, they're going to constrict, so vasoconstriction in sort of peripheral vessels, which is why you look paler when you're sort of scared. Okay, and you're in your fight or flight mode. So it's not gonna constrict all your like major arteries to your heart, because that would be stupid. You're not going to want to constrict your heart arteries when you're scared and you need to increase your heart rate. Okay, so it's only going to affect, when I say stimulate, it's only going to affect sympathetic pathways. Okay, so reason for, like I said, the vasoconstriction, that's going to increase blood pressure, and we know if we increase blood pressure, we're going to increase heart rate. Or cardiac output, sorry. Okay, so similarly, just because you say sympathetic is going to fight or flight, that doesn't mean everything is going to be triggered and everything is going to contract or constrict. Some things we need to sort of relax. So for example, our digestive system, we don't want that going during fight or flight. So we might have our beta 2 or alpha 2 receptors working. Okay, so mainly we're talking beta 2 here. So beta 2 affects all smooth muscles, organs and glands in the sympathetic nervous system. So that might mean, like I said, your digestive system. So it might cause something to do with peristalsis. I'm not too sure on that sort of concept, but that generally. I won't go into detail on that because I'm not aware. But for example, in your lungs, so beta 2 receptors are in your lungs, and these relax. So when you're in a heightened sort of fight or flight mode, you want them to relax so you can, your lungs can fill with air more. So we've got our beta 1, they're stimulating our heart rate. So our heart's pumping, but we want our beta 2 to relax our airways, because we've got all this blood rushing into our lungs to get all this oxygen. But if our lungs are contracting, we're not going to have much oxygen in there. So we want our lungs to relax to allow oxygen to enter our bloodstream. Okay, so it works two ways. Okay, so that's an example there. We've got alpha 2 receptors. Okay, these are more sort of like a negative feedback loop. We need some form of way where our sympathetic nervous system can turn itself off. So our alpha 2 receptors, they act on our presynaptic neuron, and they sort of inhibit our acetylcholine to binding to the postsynaptic membrane and that sort of thing to inhibit itself. Okay, I've not gone into much detail on these receptors just because that's not the focus of what I'm going through. it would be worth going through a more sympathetic and autonomic nervous system separately, I think, as a note to self. Okay, so our sympathetic receptors, I forgot to mention, I don't think, they're called adrenergic receptors. So that makes sense because adrenaline, noradrenaline, that's what it's just in the name, isn't it? Okay, we'll go back to them. In our heart, we've got our parasympathetic nervous system can affect it as well. So we said our sympathetic will increase our heart rate, our parasympathetic will reduce the heart rate, okay? So our parasympathetic nervous system, that comes out from our craniosacral sort of regions, so our cranial nerves and our sacral region, okay? So that's where they'll be released, their neurons will be released. So our presynaptic neuron, in this case for the heart, is the vagus nerve, which is a cranial nerve. Okay, so this is going to come out and it's going to synapse with our postgangliotic neurons. Important to note here actually is that in our parasympathetic, the presynaptic neuron is longer than in the sympathetic. Okay, so sympathetic, they synapse quite close to the spinal nerve. Parasympathetic, they synapse quite close to the effector organ. Okay, important to note. Okay, so it comes out and it goes close to the heart. It synapses with our postgangliotic neuron. Again, in this synapse, we've got acetylcholine. And that's going to trigger our action potential to go to our conductile cells. So our parasympathetic nerve doesn't really go to our contractile cells, okay? It's more associated with reducing heart rate. So how does it do that? It does that by, if we want a reduced heart rate, we want it to be harder for our conductile cells to depolarize. So how do we do that? We have our potassium cells, our potassium channels, open for longer. So we see in this part of the graph where our potassium channels are open and it repolarizes it. If they're open for longer, we're going to go below our minus 60. So it's going to be lower. So say it's now going to be minus 80 millivolts. We're now going to need to increase by plus 40 millivolts to get to our threshold, as opposed to our normal resting potential where it's minus 60 millivolts and we only need to go plus 20. So does that make sense there, where I said sort of, if you've got if you hyperpolarized your conductile cell more than it should have been, it's going to be harder to depolarize it, okay? So that's how it affects our heart. Okay. So our parasympathetic receptors, which I'll touch on briefly again, I'm not going to go into too much detail on them, but they're essentially cholinergic receptors, that's what they're called. Okay, and we've got two types. Our parasympathetic receptors, they're associated with rest and digest. Okay, so generally what do we want? We want lower heart rate, lower blood pressure, and we want sort of increased digestion in that sense. So resting and digesting, as it suggests. So we've got our nicotinic receptors and our muscarinic receptors. So I'll go with nicotinic first. So our nicotinic, they're split into two types. So we've got NN, so nicotinic nervous sort of receptors, and NM, so nicotinic muscle receptors. So as it suggests, our nicotinic nervous receptors, they're between two nerves. So our pre and our post, they're going to be between our two. And our NN, they're in the sympathetic nervous system as well. So you know I mentioned when, in this point where acetylcholine is binding between our presynaptic and our postsynaptic ganglion. So they're binding, so acetylcholine released by the presynaptic neuron, and it binds to our postsynaptic neuron, nicotinic nervous receptor, okay? However, we've also got nicotinic muscle receptors. So that's exclusive to our parasympathetic, I think. And they're on our skeletal muscle. Okay. So when our acetylcholine binds to our skeletal muscle, they're binding to nicotinic muscular receptors. Okay. So our parasympathetic receptors, I mentioned in the sympathetic, we've got noradrenaline, don't we? We've got acetylcholine in our presynaptic, and then from our postsynaptic to our effector, we've got noradrenaline. But in our parasympathetic, we've got acetylcholine and acetylcholine, okay? So we've got 2 acetylcholines. Okay, so that leads us on to our muscarinic receptors. So we've got 5 muscarinic receptors. M1, 2, 3, 4, and 5. So M4 and M5, they're not really associated in this context. They're more to do with our brain. Okay, so we can ignore them for now. So similar to our beta and alpha receptors, we've got some that stimulate and some that inhibit. In this case, our M1 and M3 receptors, they stimulate parasympathetic sort of actions. So they stimulate resting and digesting. Our M2 then is inhibitory. So just because we've got parasympathetic doesn't mean everything is going to relax. We need some things to be more stimulated and some things to be inhibited. So for example, we might want to inhibit our heart rate. So that's what we mentioned here with our vagus nerve. So that would be binding, our vagus nerve would be binding to M2 receptors on our SA node and conductile cells and our AV node. Okay? So just thinking about that. When our parasympathetic nerve binds to a heart cell, conductile cell, it's binding to M2. If it was going to bind to our M1 cell, it might be binding on potentially our salivary gland, the salivatory gland, I don't know where saliva comes from. It might be stimulated there. So our nerve might go to our salivatory gland and binds to our M1 receptor, which will stimulate, because M1 is a stimulatory, it might stimulate our saliva to be produced. Okay, can you see what I mean there? So we want to inhibit our heart, but also stimulate saliva, digestion, that sort of thing. Okay. So that's whistle-top tour on that sort of concept. Going to briefly touch on pressure volume loops, so cardiac pressure volume loops. So quite a simple concept generally. Just need to get your head around it to start with, obviously. So it's just a loop. But weird thing about it is it only looks at our left ventricle. So which is why we've only got 4 phases. We don't have atrial systole on here because it's just looking at our left ventricle. So if we start at point A, this bottom left corner, that's when our AV valve opens. Okay? So our ventricle is going to increase volume. So if our AV valves open, blood's going to pour in, volume's going to increase. Okay. At B, our AV valve is going to close. Okay. Our AV valve, got a blank there. Our AV valve is going to close. Okay. Which is more to do in this sort of isovolumetric contraction phase. But at that point, at B, we've got our end diastolic volume. So after all that relaxation, just before it starts to contract, that's our end diastolic volume at B. At A, that's our end systolic volume, okay? The end of our contraction, okay? Which means the difference between these two volumes is our stroke volume, okay? How much blood is ejected from the heart. Okay, so this green line going up from B to C, there's an increase in pressure at the same volume. So we know if we're staying at the same volume, it must be isovolumetric. And if it's increasing in pressure, well, if we're contracting something, it's going to increase in pressure, isn't it? So that's isovolumetric contraction. Okay, now C to E then, if we're losing volume and pressure sort of doing a little weird thing, then we know that's ventricular ejection. Because we know, if we remember back to our cardiac cycle graph, we've got it here actually. Of that cardiac cycle graph, we've got that little curve, okay? Now, if we look back on our thing, that's a curve as well, similar, it mimics it, okay? So that must be ventricular ejection. So initially we've got that point up until a point where it peaks, so pressure increases drastically to start with. So that must be our rapid ejection. And then the ventricular pressure starts to go down a bit. So that must be our reduced ejection. Okay, at that point, at E, we know that once it's stopped ejecting, blood's going to try and pour back in to our ventricles through our arteries, through our aorta and pulmonary trunk. So it's going to close our semilunar valves and start and cause our S2 sound. Okay, and then it's going to, we've got same volume, pressure's decreasing, so that must be isovolumetric relaxation. Okay, that was very whistle top there. Finally, I'm going to go through ECG placements. So these quite nice once you get it, but can be confusing. So here I've got my little body, my, what's that called? Rib cage, and we've got a heart inside. So we've got our 4 limb leads to start with. We've got right arm, can be called just right, left arm, left leg, or foot, F, and right leg, which could be just neutral, okay? So those are our 4 limb leads, which makes sense, they go on our limbs, or if not, they go on our torso, okay? So right arm, I think, left arm, right leg, left leg, okay? Makes sense. We've also got our V1 to 6 leads. So V1 is on our right. So if we think our heart is mostly on the left, so we've only got 1 lead on the right, and we want most of them on the left. So V1 is going to be our 4th intercostal space, just outside the sternum, okay? So we've got our sternum, and then it's going to be just outside of it, just as soon as you get into that space, into that mid-clavicle, into that, what's it called? What's it called? Between the ribs. Between the ribs. I've been talking for too long. Okay, so V2 then is going to be opposite it. So we've got our left intercostal space. We've got our right intercostal space, 4th intercostal space. Opposite then, just the same distance, we've got our left intercostal space, which is there. We're going to skip V3. We're going to go straight to V4. So that's mid-clavicular line. Okay, it's not really drawing to scale here, but mid-clavicular line, 5th intercostal space. Okay, on our left-hand side. And now V3 is going to be between V2 and V4. Okay, so that's easy to do. It probably be just on rib 5. Okay, V5 and V6. So V6 is on mid-axillary line, sort of you think like there, and V5 is going to be on like sort of an anterior axillary line, all in the 5th intercostal space. Okay. So what happens when we've got our lim leads? So at the minute we've only got 9 leads, but we know there are 12 ECG leads from our ECG like chart when we're reading an ECG. Okay, so our limb leads all come together to make these 3 extra. So limb 1, 2, and 3. Trying to get my fingers right there. Okay, so if we've got limb 1, hang on. When we've got our limb, if we've got right arm, we ignore right leg essentially, that's our neutral. Right arm connects to left leg, okay? So our right arm to left leg, that's going in this direction. That's going to be our lead 2, okay? So right arm to left leg is going to be our lead 2, okay? Right arm also goes to left arm, okay? That's going to go essentially horizontal line. So that's going to be our lead 1. So it's going to be going this way, okay? And we know our left arm goes to our left leg, okay? That's the only thing we've missed there, left arm to left leg. So ignore right leg. Left arm to left leg is sort of going diagonal through there, okay? Because we take left leg to sort of be in the middle. Even though it's on the left, it's sort of overall it's in the middle. So left arm to left leg goes that way, and that's lead 3. Okay, so we've now got our 3 leads, which are formed by our 4 limb leads, okay? Or our 3 limb leads, essentially, because the right leg doesn't really matter. Okay, so when we're looking at an ECG, these leads are essentially angles at which we can look at the heart. So if we want to look at the heart from the bottom, we want a lead that's on this bottom side. So our reference lead is lead 2, and that's because it sort of looks through the whole heart. Okay, so it's quite a good reference one, but essentially it looks from an inferior angle. So lead 2, lead 3, and AVF, which is essentially left leg. Okay, all these 3 look at the heart from an inferior point of view. Okay. So, what looks at the heart from an anterior view? So if we think about it, we're going to look at anterior view. We want all the leads that are on the heart, on top of me essentially. Okay, so that's going to be V1, V2, V3 and V4. All of these are sort of sat on top of the heart, so they're just going to look directly at the heart from an anterior view. Okay, we've now got the last view we're going to have is our lateral view, well, penultimate view. So our lateral view is sort of from the side. We're going to look at it from the side. So most obvious one there is lead 1 because it's essentially horizontal. We've also got AVL, which is left arm, V5 and V6. Okay, because you think about it, V5 and V6 are sort of curled around here. Lead 1 is going to be looking, lead 1 is going to be coming in from the side. Lead AVL is going to come in from this shoulder, is going to look down from a lateral sort of point of view. Okay, the only one I haven't gone through then is AVR. Okay, so that's going in the complete opposite direction as lead 2. Okay, so we don't really use that one because why would you look at lead AVR when you can look at lead 2, because it's just going to be the complete opposite. But I guess it could be useful in seeing if you've put the leads in the right place, because AVR should be completely opposite to lead 2. Okay? If it's not, you've done something wrong. Okay, that's the heart. That's Cardiology Part 2. I've waffled.